So as we get started, I think it's really valuable to know that in developmental disabilities, pain is actually an area that has been really underrepresented and under-researched. And this has resulted in a number of different outcomes that are unfortunate for us, for individuals with charge, in that they've often been excluded from research studies investigating how pain impacts their life, impacts their behavior, or even how to more appropriately identify pain in this population. So for individuals with developmental disabilities in general, there has been a suggestion that individuals need to experience a higher threshold of painful experiences to be able to feel pain. And that really has been debunked in more recent research in the past decade or so that suggests that we probably just were doing a bad job of identifying pain in individuals, and we were missing cues of what would indicate pain for them. So when you think about pain, one of the most important things to think about is its self-report. And for individuals with developmental disabilities, self-report may be very difficult depending on their communication approach or style. In charge syndrome, we've ran into the same situation where there had been reports that individuals with charge had to experience a higher threshold of painful experiences to be able to feel pain, meaning that while you or I might feel pain as it's starting to grow, that they didn't feel it until they reached some type of threshold. And I think that is a little dangerous for us to make that assumption without any data to support that at the moment. And actually what we have found in most developmental disabilities, individuals who experience genetic conditions or have atypical development often experience more chronic and more intense pain, particularly given the types of experiences that they go to, including physiotherapy, medical procedures, and long-term hospitalizations that would likely indicate painful experiences as well. So in charge syndrome, I've become an advocate to say that while we don't have a whole lot of research on pain at the moment, we don't have research to also suggest they're not feeling pain either. And I think if you meet any individual with charge, they're likely to tell you that they do absolutely experience pain, but that their way of reporting it might be a little bit different, or letting other folks know that they experience that pain could be different. So what I've hypothesized for this population in charge is that they actually experience a higher pain tolerance rather than a higher pain threshold. So I do think that individuals with charge have a greater tolerance build up for painful experiences than they necessarily have a threshold for painful experiences. And I think that's one of the first important points we need to make for this population. So one of the first things that I think has led to this confusion about pain in charge, or us trying to understand pain in charge, is first that, as I had mentioned, historically there has not been a whole lot of research for developmental disabilities in pain. They were excluded because they thought they might experience pain differently, that they weren't able to self-report their pain. And that's really put us decades behind other conditions in being able to problem solve chronic pain, acute pain, and really how we move forward with treatment for pain for this population. So we do have a lot more work to do. However, one of the things that makes it difficult with charge to be able to measure pain are a few key areas that we have to first look at to overcome in this process of understanding pain in charge. And one is that individuals with charge, being the leading congenital cause of deaf blindness, is that as a result of those multisensory impairments, they're likely to have a different communication approach. We have a spectrum of communication abilities in this population. So we have folks who are vocal and verbal and can form complete sentences and maintain to and fro conversations, to folks who might use a communication device or sign language, or might use a picture communication system. And there's a wide variety of combinations of those things that folks use with charge syndrome. And so when you have limited or no communication approaches, or the abstract concepts like pain haven't been built into your communication repertoire, the first big problem we run into with pain research is that we want you to self-report your pain experience. So when we ask individuals with charge, are you experiencing pain? But that abstract concept hasn't been taught to them, and they don't know that this feeling is pain, that can lead to a big challenge with us understanding what pain can look like for that population. And if they can't self-report the pain experience, then that obviously adds to the fact that they might not be getting treatment as efficiently or as effectively as they could, as you or I might be able to say. The other big challenge with charge syndrome is the result of facial palsy. So I would say probably 40 to 50% of individuals with charge have some type of facial palsy. When you use non-vocal pain assessments, what they're often looking at is a change in your facial expression. Are you wincing your eyebrows? Are you making a furrowed face? Are you grinding your teeth? Some of those things could be really difficult to identify in charge as a result of the facial palsy. So it's valuable for us to consider scales that consider the whole body change and a change in behavior for identifying pain in this population, rather than strictly looking at facial changes. And we do know that in some populations, particularly individuals who are blind, they might lack social referencing or social communicative deficits. And really, as a byproduct of their vision impairment, they miss interactions in their environment to teach people about the abstract concept of pain and relating the words pain and treatment to their actual experience. Certainly, it's really important to identify pain. When we have pain that's continuous or even acute pain that occurs multiple times, this has an impact not only on neurological development, but has an impact on our day-to-day life, our quality of life, and generally our temperament. So it's really important that not only first can we identify pain so we can provide treatment and reduce that pain experience and make somebody feel better, it's also really important that we identify pain to avoid the development of problem behaviors, or what we might call challenging behaviors. There is very clear research in other developmental disabilities, for example, autism, Down syndrome, and symptoms like that, where challenging behavior will spike when an individual has a painful experience. So we see things like self-injurious behavior, aggression, pulling out of a G-tube or a feeding tube increase when that individual is experiencing a painful situation. And really what that tells me is I'm trying to communicate to you, the other person, that I'm in pain and uncomfortable, and I'm going to take this behavior as far as I need to get your attention. We also know that if pain isn't treated, it could have an impact on attachment. Attachment's really important, and from a very early age in charge, one of the important things that we focus on is attachment. Babies are often left in the hospital for many months at a time. They return to the hospital very often as a result of some of the side effects of charge syndrome. And so we want to make sure that when we're working with individuals with charge, or as parents of individuals with charge, that we're taking time to recognize how attachment's developing. And if I'm always uncomfortable, that could have an impact on how well I attach to others around me. And last but not least, obviously, when somebody's in pain that we care about and that we love, that adds a whole lot of stress to the family dynamic. We want our child to feel better. Our teachers want us to feel better when we're at school and we're students who don't feel well. That added stress for everybody can be really hard sometimes to overcome. One area that my research lab is actually focusing on right now is the outcome of post-traumatic stress symptoms on parents of individuals who have a child with charge. We've spent a lot of time thinking about what the individual stress might be like for that child, and ways that we could hope to mitigate pain and identify pain in this population. But we've kind of forgot what that stress is like for a parent to have reoccurring hospital stays and to have life-threatening surgeries that occur multiple times throughout their child's life, or to think that they were at a window when those surgeries were done and now we have another one that we have to do. Those are traumatic experiences, and we want to see how our families are coping with that, because if they're not coping well, the odds are they're also not giving good coping skills for their child with charge to cope. And this all compounds upon each other and impacts how well we can identify pain and manage that pain in the future. So that's certainly an area beyond our understanding of just pain in charge and what we can do to mitigate the pain experience and improve that. We also need to think about how this impacts the rest of the family and the other folks that are involved in the life of that individual with charge.